Our first speaker is Professor Zhaoyang Fan from the University of Southern California with overview of intracranial vessel wall imaging, acquisition and analysis. Please.
Thank you for the introduction. Good morning, everyone. First of all, I want to thank our organizer for inviting me to give this talk. So due to the time limit, I would like to focus my talk on the intracranial vessel wall imaging. As you know, as Dr. Zhaoyang mentioned on Tuesday, vessel wall imaging has been there for almost 3 decades. And it is a modality really looking beyond the lumen. And for intracranial vessel wall imaging, the current most of research and studies focus on 3T field strength. And but originally 2D TSE, multi-slice TSE, was commonly used protocol. However, there's some limitations. For example, the slice resolution is pretty low, and sometimes there's no true cross-sectional view for all slices, which can lead to overestimation of the plug burden. So obviously 3D imaging has a lot of advantages compared to 2D imaging. For example, it can provide an intrinsically high SNR and high voxel isotropy and large coverage and more time efficiency, and you can flexibly reformat the image for the better visualization. And 3D TSE with the variable flip angle refocusing pulse has been actually commonly used for other vascular anatomies. For example, the peripheral artery, carotid artery, and the thoracic aorta. And this is very efficient, time-efficient sequence, and with intrinsic black blood property. And that's why in 2011, Johns Hopkins group applied this to the intracranial territory. And the original protocol was targeted slide acquisition. And later we proposed a whole brain coverage because, as you can see, whole brain will really save the time for MR technologists, and you can have a really large spatial coverage and really get a global picture of the intracranial vascularity. And also we propose this simple approach, flip down module, really can improve the T1 contrast weighting and suppression of CSF. From this example, you can see with and without this simple module, we can effectively suppress the CSF for better visualization. And this 8 minutes whole brain vessel wall imaging protocol, we assessed the repeatability and the reproducibility. And as you can see, all the results are excellent. So now the popular imaging protocol is 3D TSE with the variable flip angle, and the resolution is typically 0.5 millimeter isotropic. And most of protocol used in study is T1 weighted acquisition. Sometimes T2 acquisition is also optional. And fat saturation should be turned on. And either whole brain or slab selective coverage. And typically pre-contrast and post-contrast acquisition are both needed. And the most popular clinical application right now is intracranial atherosclerosis. So later, many groups continue to work on some advances in this image modality. For example, people want to expand the spatial coverage. For example, you can use the regular head coil plus simple 4-channel surface coil to cover the carotid and the intracranial territories. And also, there's some custom designed head carotid coil with much more channels, so you can really cover from the common carotid to the distal intracranial arteries. So this is some examples from China. And also, as I mentioned on Tuesday, flow suppression sometimes is not effective when the blood flow is perpendicular to the readout direction. So for example, for MCA, if you use a coronal acquisition, you see this, but if you switch to axial acquisition, you got a very clean lumen. So this really suggests that we have to be really careful. Sometimes we need to consider additional flow suppression. So some group apply the MSD or Dante module to this application. We can see they are pretty effective. However, as I mentioned on Tuesday, if you remember, both modules actually will lead to a signal to SNR reduction and T1 contrast weighting reduction because of a T2 decay effect from the MSD module or magnetization transfer effect and the saturation effect from the Dante module. So as you can see here, this is a comparison on the white matter SNR. And that's why we recently proposed interleaved FSD module for solving this problem. And our preliminary results shown here, you can see in this flow phantom, especially when the flow is pretty slow, our FSD module really can do a great job. And also, if you look at this real images from a healthy volunteer, you can appreciate the preservation of T1 contrast weighting and SNR by using FSD module. And the acquisition is still long with typical 3D whole brain or targeted 3D acquisition. The scan time can be 6 to 8 minutes per scan. So this is sometimes not tolerable in the elderly who actually comprise the majority of the stroke population. And also, as you know, 3D imaging is also susceptible to motion. So that's why in both the health volunteer study and some clinical population study, we already observed about 20% of subjects will have the motion artifact in one of vessel wall scans. So when the scan really involves motion artifact, sometimes it's really non-diagnostic. So you have to repeat in the clinical setting. So to solve the problem, one way is to really accelerate the scan. So that's why several groups have proposed using computer sensing initially in 2017 and later 2020. So you can see the scan time can be really shortened to about 5 minutes. But I hope you can also appreciate that there's a little bit blurring due to this method. So we actually work on another way recently, using the deep learning to accelerate the acquisition. So this network is called the CamWire, and as you can see, our reference is 12 minutes whole brain scan, so we can achieve the similar image quality. And this is a patient. This is a CamWire image, and this is a reference. So the delineation of the vessel wall is pretty comparable. And another way to solve the motion problem is to really introduce a motion composition approach. So for example, here we propose to use the volumetric navigator to address the bulk motion and use self-gating to address the localized motions, for example, caused by swallowing and deep breathing. So this is the sequence design. We have the self-gating module right before the space readout. And by the end of the space acquisition, we have this VNAV. And this is one example illustrated the effect of this technique. And obviously, AI has been very hot in the last few years, and people already start to apply this to this field. As I mentioned just now, so we can use deep learning for image reconstruction, and also some group from China, from US and Korea, they propose super resolution and denoising, and some point spread function enhancement. And for the next few slides, I will really focus on the using AI to automate the image and the plaque analysis. So intracranial vessel wall imaging analysis is a challenging task. It's very labor intensive and time consuming because we have a so large spatial coverage and it's 3D volume, and if you want to do manually, you have to rotate, you have to identify the plaque and rotate and to really reconstruct the best view for any measurement. So it's really expertise dependent, and sometimes the inter-observer variation prone. So machine learning driven automatic or semi-automatic review and analysis can really provide a highly reproducible and accurate analysis and achieve efficient and smooth workflow. All this can really facilitate the clinical adoption of this imaging modality. So since 2017, we start to use deep learning to work on this important question. So we propose intracranial vessel wall segmentation, and later we really implement automatic pipeline to solve this problem. As you can see, this pipeline has several critical steps. So you have to reformat and do the automatic vessel tracking. And after you have a center line, you can straighten the vessel and divide the whole segment into contiguous 2D slices. And on each slice, you can apply the segmentation network to segment the vessel wall and lumen. So, and later you can do a lot of quantification job. So the two major critical step, I think, is the vessel tracking. So for them here, and the vessel wall segmentation. That's the two step people have been really invested a lot of effort. So I just want to give an example for this vessel wall imaging automatic processing pipeline. We recently developed based on the 3D slicer. So this is a potentially open source software for everyone to use. So we evaluate this software in 10 patients with symptomatic intracranial atherosclerosis disease. And we compare the manual and auto pipeline, and the agreement is pretty excellent. And most importantly, this automatic approach can really save your analysis time. And this example, the patient has a stroke attributed to captured plaque in the left MCA M1 segment. So after 5 months medical therapy, you can see with this automatic software, we can really subjectively demonstrate several quantitative markers really drop after medical therapy. So this can tell us therapeutic response in this patient. And obviously, other group also work on the similar software. For example, this work from Shenzhen, they can do their pipeline actually work on both intracranial and extracranial vessels. And this is pipeline from Seattle group can do the multiplanar, multi-contrast, and multi-time point analysis. So in summary, high-resolution vessel wall imaging based on 3D TSE can provide the information beyond luminal stenosis. Continuous technical development is ongoing and highly needed to further improve the blood suppression, imaging speed, motion robustness, and image analysis workflow. So multidisciplinary collaborations are really needed to identify clinical needs and technical limitations and refine technique and protocol for better quality and streamline the workflow. And also we can hopefully we can regularize the evaluate new technology and in research and clinical settings. So finally, I want to thank my collaborators and the funding support. Thank you very much.
Thank you, Dr. Zhaoyang Fan, for the detailed explanations. Wonderful. There's time for questions. Is there somebody who wants to know something more? So my question is is this technique ready for the clinical duties? Is it used every day in your hospital?
Yes, I would say yes. Actually, in many academic institutions, they start to really adopt this in their clinical workflow. So it's really up to the stroke vascular neurologist. So whenever they think visual imaging is useful, they will directly prescribe this protocol in their order.
Thank you.
Hi, very nice talk. So
Thank you.
I have a question. Could you comment about the performance of intracranial visual imaging on 3 Tesla and 7 Tesla MRI?
So, to be honest, I have relatively less experience on the 70, but based on the field work, collaborative work, I can see right now the 70 still has a problem due to the field inhomogeneity. So you will see sometimes the image is not homogeneous. So maybe in some location, major arteries, you can really identify the lesion, but some distal artery, the signal is really low. So I guess there's still some room for 70 to improve.
Thank you very much. We have to move on with the next presentation.